It is almost the end of your first week of internship and you guys have planned to go out tonight, go for some drinks, have some food. However, your favorite senior resident calls you up at about 5 p.m. and says he's got an admission for you. And the case goes like this. A 45-year-old male with a past medical history of diabetes, hypertension, presents after a syncopal episode. The patient states that he's been feeling a little ill lately. He complained of a dry cough and generalized malaise for the past 1 week. This morning when he was walking to the bathroom, he started to feel faint and also felt a sensation of blacking out. Next thing he recalls is his wife standing over him and calling his name. The wife tells you that he was out for about 5 minutes. He wasn't confused upon waking up. EMS was called and on EMS arrival, patient's blood sugar, oxygen saturation and blood pressure was within normal limits. So based on the history that's presented to you, what do you think this patient has? When the guy was actually standing and he was walking to the bathroom, during which time, poof, the guy collapses. This is what we call as syncope. Alright, now syncope is a very important, a very interesting topic and you are going to see so many admissions that comes in because of syncope. The question is, which patient requires which workup and which patient is going to be admitted in the hospital and which one can actually go home. So it all depends on the patient's presentation. So history taking is a very crucial component of a patient who's presenting to you with syncope. So I'm going to give you guys a mind map by which we are actually going to take care of this patient's case. So based on this patient's presentation, clearly you guys know when this guy was trying to walk from the bathroom, suddenly he felt dizzy, he felt lightheaded, he felt like he's going to black out and poof, the guy collapses. And this is what you define as syncope. So syncopal episodes and syncope as a admission diagnosis, you are going to see a lot of cases during your internship. So the question is, what is the workup for a patient who's presenting to you with syncope? So again, how we are going to take care of this patient's case is going to be a little different from the previous cases that we've dealt with. We're still going to follow the same format of physical examination, labs and orders, and finally assessment and plan. So I'm going to give you guys a mind map which you're going to be using to work out your differential diagnosis, and based on the differential diagnosis that you're suspecting, you will place the appropriate orders and work up your patient for this admission. So let's dive right into it. So the basic workup that you're going to do for syncope is actually dependent upon the possible differential diagnosis for your patient with syncope. However, it is very simple and it's very easy for you to remember what the possible differential is. How we're going to do it is based on our syncope man over here. Now when you look at this patient, I want you to recall and I want you to remember it on yourself. Alright, so the patient number one is going to be brain, right? So the patient could have some form of neurologic dysfunction. What neurologic problem can give you syncope? So let's look at this. So neuro, you have stroke. So clearly if a patient is telling you, oh, I have some form of dysphagia, I have some form of slurred speech, or I have some form of limb weakness. So when the story tells you the patient is having some form of neurologic symptoms suggestive of stroke, you could think, all right, the patient probably has stroke. And clearly if you're suspecting a stroke, you're going to follow the previous episode that we did on stroke. So you get the point, but a stroke could definitely present with syncope. Number two, in neurological, you have seizures. So clearly the patient may have had some form of generalized tonic-clonic seizure or some form of complex seizure which eventually led to the loss of consciousness. So when you're asking a history from a patient who's having a syncopal episode, it's very important for you to ask, alright, so how did it actually happen? What caused this patient to have a syncopal episode? Did he have some form of aura prior to the happening of a seizure? Oftentimes when you have an aura, it essentially says the patient is having some form of temporal lobe firing, which is going to be giving you the aura. However, the patient, important thing is when somebody has a seizure, oftentimes it could be witnessed by somebody, the patient may or may not remember the presence of seizure. Another important thing is, important questions you're going to ask. Did the patient pass urine on the patient self? Did the patient pass stool on himself? Did the patient have tongue biting? Another important thing is, once the patient actually gains consciousness, a patient who had seizure is not going to be completely aware where or whatever happened, he'll be very confused. This is known as the post-ictal phase. So when you're thinking of seizure, you must get a pre-ictal phase, an ictal phase, and a post-ictal. So your history has to be pertaining to a possibility of seizure. So you are going to ask this history from every patient that comes, because seizure is part of your differential diagnosis. Alright, number 3 is psychological. I know you guys are in internal medicine residency, however psychological issues can give you syncope. We are the guys, we actually think broad always, right? We don't narrow our minds just to the medical problems that can give you a presentation. So it's very important for us to think of psychological. Now when you think about it, what is psychological going to give you somebody syncope? It may be syncope but may just look like syncope. Alright, so the important condition you must remember is conditions such as conversion disorder, where an emotional stimulus is going to cause the patient to have some form of physical symptom. So conversion disorders can give it. You can also have pseudo seizures which can give you this kind of presentation. And again, I also want to remember patients who are having sleep disorders such as narcolepsy, cataplexy. All these patients could immediately have some form of sleeping episode, which is oftentimes can be misinterpreted as a syncope. So it's very important for you to get history based on this as well. Next, we're going to look at the patient's neck. So you're done with the face where you have the brain. Number 2, you see this red vessel over here. What is this vessel called, guys? It is known as your carotid. Now carotid is very important because if you go back to your physiology in step 1, you'll recall that carotid is basically what is going to be controlling your baroreceptor reflex. So anytime you stimulate your carotid artery, you're going to stimulate a parasympathetic response, causing your heart to slow down, and this is going to cause decreased cardiac output. That's going to cause decreased blood flow to the brain and eventually going to cause syncope. What you need to remember is this is basically what we're going to call as a vasovagal syncope. Alright, because you're talking about your vasovagal response. So this one you're going to remember as a vasovagal syncope. Now what would cause somebody to have a stimulation of the vagal response? It's very simple. You guys already know the answer to this. When somebody is having a chronic cough, chronic bouts of cough, right, you have increased intrathoracic pressure, that causes stimulation of your baroreceptor reflex. If somebody is constipated and is straining heavily, right, that can cause a baroreceptor reflex and cause syncope. If the patient is having BPH, benign prostatic hyperplasia, or the patient has got some form of prostate cancer and is having a very difficult time passing urine, this straining can cause a baroreceptor reflex. And now a really fun one which people love to ask you questions about is people actually have carotid hypersensitivity. So I want you to remember the carotid for 2 things. One is your vasovagal and the other one is going to be your carotid hypersensitivity. Alright, hypersensitivity, basically saying these patients have a very sensitive carotid artery. For instance, a child comes and hugs the grandfather around the neck. Boom, the guy is gonna collapse. And this is one of the reasons, this is one of the presentation of carotid hypersensitivity. Another person is probably getting ready to go for his interview, so he decides to put on a nice shirt, buttons the topmost collar button and puts on a tie. And this alone can cause carotid hypersensitivity. Or somebody decides to shave and they're shaving, during which time you're going to stimulate your carotid, and this can cause syncope. So when you think of the carotid from our beautiful picture over here, I want to remember 2 things. One is vasovagal response and number 2 is carotid hypersensitivity. Alright, so you're done with the brain, you're done with your carotids. Let's move on to the big one, which is going to be your heart. Alright, now heart I want you to see as 3 or 4 important things. In fact, you must remember it as 4 important things. Alright, when you look at the heart, so basically I want you to see it as this. Number 1 is blood vessels, number 2 is valves, number 3 is the patient's chambers, number 4 is gonna be arrhythmias. It's that straightforward. So if you think of the patient actually coming with the possible coronary artery disease, the patient is going to come with chest pain. You already know how to deal with when somebody comes with chest pain, but again, remember syncope could be a presentation of a acute MI. So you must keep that in mind. Number 2, you can have heart failure. If a patient is coming with a very low ejection fraction, maybe the patient never had a history of heart failure in the past, but now is presenting to you with a new onset heart failure where syncope could have easily been a presentation. So you're going to ask history pertaining to that as well. Number 3, valvular heart disease. Now, valvular heart disease, as you guys know, could cause syncope, right? Which are the ones which are very famous to cause? If you think of older people, immediately you're going to think of aortic stenosis. The triad of symptoms that you get with aortic stenosis, one of which is in fact syncope, right? So syncope could happen with aortic stenosis. Now, if I told you a young person comes with syncope, you're going to tell me, oh well, maybe there's two possible things here. It could be a mitral valve prolapse, or it could be HOCM, right? These things could also cause it. What about tumors? Could tumors cause syncope? Absolutely. If the patient had a atrial myxoma, that also could give you a syncopal episode. So there you go. You see, once you look at the valves of the heart, you automatically know which ones are going to be causing it. So you're going to ask history pertaining to this as well. Finally, you got arrhythmias. Clearly, all of you guys already know important arrhythmias can give you rise to syncope, right? It could be atrial fibrillation, it could be atrial flutter, it could be supraventricular tachycardia, it could be anything. So always remember, you're going to ask for questions pertaining to arrhythmias as well. All right, so we're done with the heart. So you're done. See, neuro, you already know, right? Neurological, done. Number 2 was your carotid, which has two components, vasovagal and carotid hypersensitivity. You came to the heart, where you branched out into 4 things: arteries, heart failure, valves, and your arrhythmias. All right, so fine, let's move on to the 4th component, which could be dehydration, right? The reason I put the gut is because I feel like dehydration, diarrhea, it makes sense. It makes you remember, it makes it stick. But however, you guys already know, anything like anything could give you dehydration. All right, so dehydration is important. So when you ask for the history, you'll ask the patient, have you been feeling well lately? Have you been feeling ill? Have you not been eating or drinking properly? Maybe the patient had immense amount of diarrhea and has not been taking enough fluids. So diarrhea can give you dehydration, and you know dehydration eventually can cause orthostatic hypotension, which will result in syncope. All right, so finally, last but not least, is pulmonary embolism. There has been studies which have shown that people who are presenting to the hospital with syncope had a good amount of incidence of pulmonary embolism. So you must keep pulmonary embolism in the back of your mind. The reason I put it in the leg was obviously pulmonary embolism has to form somewhere before it travels to the lungs. So always think of pulmonary embolism as well when you are dealing with a case of syncope. Alright guys, so this is your basic format you are gonna imprint into your brain. Alright, you're gonna go neuro, carotid, heart, dehydration, and pulmonary embolism. So I hope this mind map has been imprinted onto your brains. So now, because you know this mind map, you know exactly what history to ask, and you also know what physical examination you are going to do. So we have to do a very thorough head to toe physical examination. So I'm just going to go over what specific findings you're going to look for and what you would find in these possible differential diagnosis. Stroke, pretty straightforward. You guys can already watch my previous lecture, which is on strokes. You know the neurologic deficit that you're actually going to look for. Number 2 is seizures. Seizures is very important because what you're going to do is you must look at the patient's mouth. What you're looking at the patient's tongue to see if there was some form of tongue biting. Alright, you are also going to assess the patient's mental status. Is the patient alert, oriented to time, place, and person? Because if the patient had a seizure, then this patient could be in having a post-ictal phase. So that's important too. Number 3 is psychological. Now psychological you could assess, but again you're going to do a mini mental status examination. If you're suspecting some form of psychiatric condition is present, then you'll evaluate the patient for that as well. Then let's move on to the carotids. Now vasovagal, it's important, and how you're going to identify this is if the patient gives it to you in history. All right, so you're not really going to do a test per se right from the beginning. Number 2, carotid hypersensitivity. Oftentimes what you could do is do a small carotid massage, which could actually precipitate a syncopal episode. So you could do that test, okay, for carotid hypersensitivity. Let's move on to the heart. Now heart, you're gonna, if the patient is having a coronary artery disease, maybe you might find some form of S3, because this coronary artery disease, acute MI, is causing an acute heart failure. At that point you can get an S3. However, most of the time if somebody is having an acute MI, you're not going to have any physical examination findings per se. Heart failure. Now heart failure, obviously you guys can watch the previous lecture which we did heart failure already. All the physical examination signs you will look for. Number 3 is valvular heart disease. Now here is important because the murmurs are going to be reflective of the valvular pathology. Alright, so your hearing has to be good enough because initially you don't have an echo to tell you what the valvular disorder is. So make sure you guys remember your murmurs excellently. Alright, so number 1 is aortic stenosis. Aortic stenosis, as you guys already know, you will get an ejection systolic murmur which begins in your aortic area and it radiates to your carotid, right? It's ejection systolic, it's crescendo, decrescendo. Alright, so that is an important murmur that you must remember with aortic stenosis. Mitral valve prolapse is mostly seen in younger adults, and what happens is your mitral valve, the cusps are very loose such that when the ventricle contracts, the cusp kind of goes back up like this and forms a click at the mid of systole. So you'll get a mid systolic click, and after a point, once the cusp gets more and more flappy, ventricle starts to contract, boom, it goes up, click and shh, goes up, click and shh. So you can get a mid systolic click followed by a late systolic murmur, which is very characteristic of mitral valve prolapse. And oftentimes what happens is mitral valve prolapse in the long run is going to cause a mitral regurgitation, which is going to give you a pan-systolic murmur. Thirdly, you have HOCM, which is hypertrophic obstructive cardiomyopathy. HOCM occurs again in younger adults, okay? Younger males is where you're going to see HOCM. The murmur that you hear with HOCM is absolutely the same as aortic stenosis, which is an ejection systolic murmur. However, the maneuvers that you're going to do is going to differentiate the two. I want you to remember that all left-sided murmurs will increase in intensity if you increase the preload, whereas a patient with HOCM, you already know if you increase the preload, it actually improves the murmur with HOCM. Again, we'll deal with this in valvular heart disease specifically, and we are going to really dive deep when we get there. Now, finally, you can also have an atrial myxoma, which is a tumor present in the atrium. It goes and clumps up your mitral valve and prevents your blood flow into the ventricle, and this can cause syncope as well. Alright, now when you go into arrhythmias, clearly on physical exam you're not going to find much. It's going to be more on your EKG, which you're going to get to do, right? Next, you can have dehydration. Now dehydration is very important because oftentimes in the history you're going to get the story already. The guy has been sick, he's not been eating, he's not been drinking, so you should think of dehydration. So when the patient comes into the hospital, rule number 1, what you must do is not give this guy a big bolus of 1 liter. What you should do is vital signs. You want to get this patient's blood pressure, and you also want to do orthostatic vitals, okay? So you want to do orthostatic vitals, which is going to tell you if the guy is dehydrated or not. So number 1, when the ED gives you, make sure you see the patient immediately and do orthostatic vitals. And yes, if the patient is orthostatic positive, then you will give the patient IV fluids. Alright, so remember, orthostatic vitals is going to be very, very important. Last but not least is pulmonary embolism. Now pulmonary embolism, you will do a modified well score, and based on your modified well score, you'll determine how you're going to play with this. Are you going to get a D-dimer, which is a screening, or are you going to pursue a more diagnostic test such as CT angiography or a VQ scan if the patient has got kidney dysfunction? Again, we'll be dealing with pulmonary embolism separately in the upcoming days. Alright guys, I hope you guys are getting my drift here. Now let's move on to the labs and orders. Now what labs are you going to order on this patient? Let me write it right up here. Are we going to get a CBC? Sure, we can get a CBC as a baseline. Are we going to get a CMP? Sure, we can get a CMP, because CBC, if the patient has anemia, hemoglobin is low for whatever reason, the patient could be having a syncopal episode, right? So you want to get a baseline hemoglobin to see if that is part of the problem or not. CMP, again, as I said, the patient could be dehydrated, and I've told you multiple times, when a patient comes to the hospital for whatever reason, they always end up getting a acute kidney injury. So you want to get a creatinine on this patient. And apart from that, as you guys already know, I said arrhythmia was one of the reasons why the patient is going to present with a syncopal episode. So what are you going to look for? You must look for potassium levels, magnesium levels, calcium levels. These are going to give you very crucial information. Do not ever order a test for the sake of it. It must have a reason why you're ordering it. If you don't have a reason, do not order it. So CBC, CMP, fine. Number 3, what else can we order? You could order a PT, PTT, INR. Again, if you're suspecting the patient probably has a pulmonary embolism and you want to give this patient some amount of anticoagulation or some form of therapeutic procedure you're going to do, it'll be good for you to get a baseline PT, PTT and INR. Alright, what else are you going to order in this patient? Again, are you going to get a EKG? Yes, you are. The reason EKG becomes critical in all patients with syncope is because when the patient presents to you, and oftentimes you're not sure as to what the story really is, alright? Sometimes the patients are very poor historians. So however, you know arrhythmias could be present, so you must get an EKG to find out if there's an arrhythmia. Again, chest pain, the patient could be having an acute myocardial infarction. For that reason, you must get a EKG. The moment you say EKG, what's the next thing you want to think of? Another lab test that you must get. You could get a troponin. Are you going to get troponin on everybody? Absolutely not. If you're suspecting the patient is probably having chest pain and you want to make sure the patient is not having a myocardial infarction, at that point you will get a troponin as well. What other tests are you going to order? So these seems like the pretty basic tests that you're going to order. Now again, you're going to individualize whatever other tests you're going to do. Stroke, as you guys already know, you're going to get a CT head, MRI, CTA, MRA and echo. Again, we've already gone over all those things in the stroke lecture. Seizures. Clearly, if you know that the patient has been intoxicated with some form of substances, if the patient has some electrolyte abnormalities, right? If you have a reason for why the patient is actually having a seizure, you don't have to do the $1 million workup. If you do not have a reason for why the patient is having a seizure, you might consider doing an MRI because you want to look for any form of structural defects that could be present, which is giving rise to seizures. And number 2, for the same thing, what you could do is a EEG. Because EEG is basically the electrical map of your brain. It's going to tell you if the patient has a seizure focus or not. Alright, psychological, again, call psychiatric consult and let them take care of it. I'm just kidding. Psychological, you must still know, you must try to investigate it further, but again, there's not really any form of lab or any form of test that you could do to diagnose. It's going to be more of a clinical diagnosis. Alright, fine. Now carotid, as we said, vasovagal. You could, for carotid hypersensitivity, do a carotid massage and you can figure that out. Now with regards to vasovagal, you guys probably heard about this test known as tilt table test. You don't have to do a tilt table test on everybody. All right, if a person is coming to you and saying clearly, I've been constipated, I have been straining in the toilet for the past 30-40 minutes, straining his life away, and this caused a syncopal episode, you clearly know it's vasovagal, so you don't have to do a tilt table to provoke this. But for whatever reason, if a person comes with syncope and you've ruled everything out and you really suspect vasovagal and you really need to prove it, then you'll do a tilt table test. Do not just simply throw tilt table test into every patient. All right, fine. Heart. Now coronary artery disease, as we already said, you're going to get an EKG and a troponin. Perfectly fine. If you're suspecting heart failure, you're going to get a echocardiogram. If it's a valvular heart disease, again, you're going to get a echocardiogram. Arrhythmia, you're going to get your EKG, which we already spoke of. However, if your patient does not have a baseline abnormal rhythm, but you're still suspecting, all right, this guy probably has some form of arrhythmia, you could clearly put the patient on a Holter monitor for 24 hours, and if that doesn't catch it and you still suspect the patient probably has some form of abnormal cardiac rhythm, what you could do is a loop recorder with which the patient can go home with. All right, lastly, you have your dehydration over here, which is pretty straightforward. As I already told you, you're going to get your orthostatic vitals, which is going to tell you what the answer is. And again, you could give the patient fluid and see if it improves. That's like a confirmatory test. It basically has a diagnostic and a therapeutic value by giving fluid. Again, we're going to take care of pulmonary embolism in a separate topic, which is going to be completely dedicated for pulmonary embolism. But again, the test you're going to do if you have low suspicion is D-dimer. If it's a higher suspicion confirmatory test, you need a CT angiogram angiography, but if the patient's got a kidney dysfunction, you're going to go with a VQ scan, which is a ventilation perfusion scan. This concludes our labs and orders. Again, everything has to be individualized. You're never going to order all of these tests on every given patient. You must choose and pick based on what you are suspecting in these patients. Okay, all right guys, so this brings us to the final component of the lecture, which is going to be on assessment and plan. As you guys already know, assessment and plan is basically where an intern shows the attendings as well as the senior resident that they know what they're talking about. All right, so the difference with assessment and plan of patient with syncope is a little different because they're not really treating a condition, is it? Syncope is not a condition. Syncope is more of a symptom which has so many different causes. We're going to treat whatever the patient is coming with. So I'm just going to quickly run through what you're going to do, because most of these topics are covered individually and you guys can watch that because you guys need to learn it completely well. However, I'm just going to quickly run over the management for different conditions. If the patient presents with stroke, you guys already know, you can give the patient TPA, you can give the patient mechanical thrombectomy, and if the patient is outside the therapeutic window, you can give the patient aspirin if never been on aspirin. But if the patient was already on aspirin, you can either switch to clopidogrel or add dipyridamole, and you can continue the combination known as Agri-Nox. Alright, seizures. When a patient presents with seizures, normally for a first time seizure, you do not start them on anti-epileptic medication. All right. However, if the patient comes the first time seizure and you do an MRI and you see this tumor, now if the patient has a reason for why he's having seizure, he's always going to have seizures because this lesion is always going to be present. That's one important reason. And if the patient's got an EEG done and you see the patient has an epileptiform focus, something that's giving you seizures in this patient, these patients can be on anti-epileptic medication. Question is, which one are you going to start, right? There's multiple different medications out there. However, the one that is very much favored these days is something known as levetiracetam, which is known as Keppra. The reason this medication is very much favored is because it has the least amount of side effects. All right, psychological, again, you guys already know what to do for those things. Counsel the patient and take care of what psychological issue that's going on. Next, carotid, vasovagal. Oftentimes what happens is you're pooling a lot of blood in the lower extremities and therefore the blood doesn't really come up, right? Think of it something like orthostatic hypotension. So if a patient has vasovagal syncope, you can actually give them stockings, right? You can give them stockings to prevent the stagnation of blood. You must also remember a lot of older people, okay? Older people are going to have a lot of vasovagal syncope. Reason is, again, they can have BPH, they are constipated, right? Apart from the important thing is autonomic dysfunction can happen in older people. Let me ask you this question. What if a patient came to you and the patient's got a mask-like face, he's got this resting tremors in his hand, and this patient all the time when you test him for, he has orthostatic hypotension. What condition am I talking about? If you guys are saying Parkinson's, yes, you're absolutely correct. But this is a special syndrome that actually causes the orthostatic hypotension due to autonomic dysfunction. What is this one called? It is called Shy-Drager syndrome. You basically treat the patient's Parkinson's and the Shy-Drager syndrome can actually improve. So remember, Shy-Drager syndrome is orthostatic hypotension plus Parkinson's disease. Alright, so fine, you were done with your carotids. Now let's move on to your heart. Again, all of these you guys already know, you're going to treat it individually. Dehydration, pretty straightforward. What you're going to do is you're going to give the patient IV fluids. Remember, it is diagnostic and therapeutic, right? So IV fluids becomes an important part of dehydration. And lastly, we got pulmonary embolism. As I already said, your screening test or your confirmatory test, what to do. Now, management of pulmonary embolism also depends. In those patients who are actually having very severe pulmonary embolism, which we call as massive pulmonary embolism with a drop in blood pressure, your treatment becomes one of three things. You can either do an open heart surgery and remove this large clot, because most of the time when somebody has a massive pulmonary embolism, you've got this really large clot sitting in your lungs, so you got to remove it, right? So if you have hemodynamic instability in the context of PE, then what you're going to do, best treatment is in fact open heart surgery and remove the clot. However, if patient is a poor surgical candidate or does not want to undergo open heart surgery, then your options are, you can give TPA, okay, you can give them TPA, or what you could do is you could go with a catheter and suck out these clots from the lungs. So again, as I said, treatment differs, it depends depends on what the patient is presenting with. And again, I'm going to be covering pulmonary embolism in a different section as well. Alright guys, so we have gone over syncope. The different view of syncope, the way you see syncope is different compared to the other cases, because syncope is not a disease, it is a symptom. It is reflective of any one of this. So if you have this in your mind, you should be able to ask the right questions, you should be able to do the right physical examination, you should be able to place the right orders, and you should be able to give them the correct treatment. Alright guys, I really hope you enjoyed this video and learned as much as possible, because if you know all of this, what I've just told you on this one whiteboard, you should be good to be a very solid intern. Thank you so much for watching this video. Please hit the subscribe button if you haven't already done so, and also hit the bell button to get notification of the upcoming videos. And as I've already told you, we will be covering each and every one of them as a separate topic.